Hi everyone, this is a lecture for Chapter 51, Caring for Clients with Diabetes Mellitus. Now, I'm going to go over real quickly what the learning objective is for this chapter. I like students to be able to identify and distinguish the two types of diabetes, which is type 1 and type 2. Also identify the three classic symptoms of diabetes. I'd like you to be able to name three lab tests or laboratory methods used to diagnose diabetes. You should be able to describe the methods used to treat diabetes. Also identify different categories of medication used to manage diabetes and how does it work. Also like you to discuss nursing management of client with diabetes, explain the source of ketones and the causes of diabetes, ketoacidosis, and the three main goals in the treatments of diabetic ketoacidosis. Also want to go into two physiologic signs of hyperosmolar hyperglycemic non-ketotonic syndrome and describe the treatment for that syndrome and also explain the cause and treatment of hypoglycemia, differentiate the signs and symptoms between hypo and hyperglycemia, also describe common chronic complications of diabetes. So there's quite a bit of objectives for this chapter, so let's dive right in. Okay, so what is diabetes mellitus? So diabetes mellitus, we usually abbreviate into DM, is actually a systemic metabolic disorder that involves improper metabolism of carbohydrates, fats, and proteins. Now, a lot of experts believe that diabetes is a consequence of metabolic syndrome that includes several things, such as obesity, especially fat deposit in the abdominal area, patient displaying high blood pressure, labs showing elevated triglycerides, low density lipoproteins, their blood glucose level is high, and also a low high density lipoprotein level. As scary as it is, approximately 90 to 95% of adults actually acquire this disorder. So let's take a look at the map provided by International Diabetes Federation. This is the ninth edition since 2019. So take a look at the diabetes worldwide. So diabetes worldwide, if you look at North America and Caribbean here, we at this time, let's look at the 2019, have 48 million people with diabetes. And this is actually a predicted amount of increase to 2030 and 2045, which will increase about 33%. Now that means 1 in 6 adults in this North America is at high risk for developing type 2 diabetes. Looking at other regions here, Africa is looking to see a 143% increase, which is really high. Same with Middle East and North Africa, 96% increase. Now, as a whole entire world, there's going to be about, currently is more than 463 million people, and after another 10 years, it's going to be 578 million people that's going to be diagnosed with diabetes. And imagine, another 15 years from then is going to be 700 million. That's 51% increase. All right, so this is very scary. We got to treat this seriously. Coming back to our slide, it did point out that this is the 7th leading cause of death in the United States, and estimating about 23.6 million people today have diabetes. And we know this number is not as accurate because, let me show you another graph. So here it is, according to the International Diabetes Federation, back in 2010, we already have 37 million people. Notice that these are estimates from people who are age 20 to 79, and these are people with diabetes in thousands. So you have to remember this number here, you have to add 3 more zeros to it. So that's about 37 million. In 2019, which is the most updated data, we already have 47 million going on to 48 million. So what we have in our textbook is underestimated, all right? And incidents do actually increase a lot more among the African Americans, Latinos, Native Americans, also is increasing in Asian Americans. So I want to ask you guys, what do you see here? So I hope you can identify quickly that this is a person who's overweight or obese, right? So why is this important to know? Because before we get to be diagnosed with diabetes mellitus, there's also something called pre-diabetes mellitus. So we have identified people with pre-diabetes associated generally with a patient who's overweight or obese, and we would like to also see their hemoglobin A1C. If their hemoglobin A1C is abnormal, which is between 5.7 and 6.5%, this also basically means the patient is in the pre-diabetes stage. And we will also look at their fasting blood glucose and glucose tolerance. So if there's any abnormality of these three blood glucose levels and that patient is obese or overweight, this puts the patient at a really high risk for getting pre-diabetes. So let me just recap what HbA1c is. HbA1c is what we call glycated hemoglobin, and this developed when our hemoglobin, which is a protein with red blood cells, and usually what it does is it carries oxygen throughout our body, right? But when the hemoglobin joins with glucose in the blood, it becomes what we call glycated. So by measuring this hemoglobin A1C, we're able to see an overall picture of what the patient's average blood sugar level have been over a period of 2 to 3 months. So for people with diabetes, this is also very important to measure. The higher the HbA1c, the greater the risk of developing diabetes-related complications. So in pre-diabetes mellitus, it's very scary. It can lead to type 2 diabetes, other type of heart diseases, or stroke. Now, so the three things that we look at to diagnose someone with pre-diabetes is, again, HbA1c, level between 5.7 to 6.4. Impaired fasting glucose level is 100 to 125, or the impaired glucose tolerance level from 140 to 199. So the goal for patient who's in the pre-diabetes is to maintain normal insulin and glucose level and to avoid the onset of diabetes. And how do they accomplish that? By diet changes, exercises, and additional medication if needed. All right, so this is provided by CDC, which is a diagram showing you how you can get to type 2 diabetes. Okay, so if you're normal, you should be able to see your A1C test below 5.7%, and your fasting blood glucose test should be below 99. And we know that our body try to keep it between 70 and 100 milligram per deciliter when we have our normal blood glucose maintained with the release of insulin, should be between 70 to 100 for fasting blood sugar tests. And the glucose tolerance test, if you're normal, it should be below 140. So you can kind of take the ups and downs, the diabetes and the normal, and what's between them will be the pre-diabetes. Okay, so it's important to know these values. So now let's take a look at definition of hyperglycemia. I know that you guys already know that the medical term means an elevated blood glucose level. And so I want you to think about some of the other causes that could associate with hyperglycemia. So if you look at your textbook, table 51-1, there are other conditions that can associate with hyperglycemia. So first thing is you need to think about whether or not your pancreas is working. So people who have pancreatitis or pancreatic tumor or cancers can also cause hyperglycemia. Another thing is if your patient has any other endocrine disorders such as Cushing's syndrome or acromegaly or pheochromocytoma, the one we talked about, and hyperthyroidism can all cause hyperglycemia as well. Sometimes this is drug induced, so people who are taking additional steroids like corticosteroids for athletes, that could cause hyperglycemia as well. Sometimes oral contraceptives, estrogens, and people who have bipolar disorders may be taking lithiums. Those are all medications that can induce hyperglycemia. Also, it could be induced by virus, such as cytomegalovirus, mumps, and adenovirus, or rubella can also cause hyperglycemia. Another thing would be any genetic disorders, such as someone who has a Down syndrome, which is what we call trisomy 21, or patients who are pregnant, they could be experiencing gestational hyperglycemia, as well as those who are taking total parenteral nutrition right here. So they're not ingesting the food through their mouth, they're actually getting their nutritions through their IV lines. So these are all common causes of hyperglycemia, something to think about. Now let's look at the two main type of diabetes, type 1 and type 2 diabetes. Type 1 diabetes was formerly called juvenile diabetes or juvenile onset diabetes. Sometimes we also call it insulin-dependent diabetes. And whereas type 2 diabetes was formerly called adult onset diabetes or non-insulin dependent diabetes mellitus. So that's what the abbreviation means, IDDM versus NIDDM. Okay, so IDDM is insulin dependent diabetes mellitus and NIDDM is non-insulin dependent diabetes mellitus. So for type 1 diabetes, basically there is no insulin resistance because there's an absence of insulin production. So this is diagnosed when the patient's pancreas does not produce any insulin or very, very little insulin. And this insulin must be obtained through other sources, such as administering the insulin via subcutaneous route or using insulin pump or injection. So let's recap real quick what are the functions of insulin. So the insulin can carry glucose into body cells and they can make them preferred source of energy. It can also promote liver storage of the glucose as glycogen, and it will stop the breakdown of glycogen back into glucose. So now if you can think of normally when we start to intake our food, then metabolism begins. When metabolism begins with our intake of food, it can change glucose, fatty acids, glycerols, and or amino acids are then absorbed into our circulation and carried to our liver, right? So the liver stored these for either immediate use or later use. Now the liver can change glycerol and fatty acid into glucose and then glucose into triglycerides as needed, as our body needs it. But when glucose is not available as the fuel or cannot be used, then the liver will change fatty acids into ketone bodies. So as you know, there are three ketones available, or three types. One is what we call acetone. Second type is acetic acid, and the last type is called beta hydroxybutyric acid. And these are basically serve as fuels for our muscles and also as energy source for our brain. But when ketones accumulate too much in the blood, the clients with diabetes are at risk for developing a form of metabolic acidosis known as ketoacidosis. And in type 1 diabetes patient, ketoacidosis do develop very suddenly because it means the body totally stopped producing insulin. Many studies have been done, and we have now pretty much considered type 1 diabetes as an autoimmune disorder. This autoimmune disorder causes progressive destruction of beta cell functions in the pancreas. So basically, as you know, autoimmune disorder means our own T cells identify whether or not the cells are normal cells or the cell in our body is a foreign cell that needs to be destroyed. So someone with type 1 diabetes, their T cells thinks that the islet cells are actually foreign, so they start to destroy them. So many have believed that this autoimmune beta cell destruction is attributed to some sort of genetic predisposition or genetics plus infections or plus some viral agents that could cause this to happen. Okay, now let's look at type 2 diabetes mellitus. Type 2 is different from type 1. As you know, type 2 diabetes often is diagnosed after the patient has suffered from high cholesterol, high blood pressure, noticeable obesity or overweight, and the key is this is insulin resistant. So some patients with type 2 diabetes were not diagnosed until later time, and they have been in this insulin resistant stage for some time. Now, some of the pathophysiology factors that have been identified related to type 2 diabetes include three things. Number one, it could be due to decreased tissue responsiveness to insulin as a result of the receptors or the post-receptor defects. Two would be overproduction of insulin early in the disease stage, but then eventually they decrease the secretion of insulin, which is then the result of this beta cell being totally exhausted. So later on, they start to increase less insulin. Or it could be due to abnormal hepatic glucose regulations. Okay, so these three factors are important to understand why this is a type 2 diabetes. Okay. A lot of times, type 2 diabetes runs in family. So it is sort of an inherited disease. Just like I mentioned before, so with type 2 diabetes, usually the cause is related to a decreased tissue responsiveness to insulin, right? So scientists have found that obesity and type 2 diabetes is directly linked. Their findings saying that chronic low-grade inflammation is a result in insulin resistance. So the tissue is not sensitive to insulin at that tissue level. So therefore, your body will try to compensate when you have increased amount of sugar in the bloodstream, which we call that hyperglycemia, right? So in order to get rid of the body's abnormal amount of glucose, your kidney will try to excrete it in the urine. So when the kidney excrete the sugar in the urine, we call that glycosuria, right? Abnormal presence of sugar in your urine. So when you have glycosuria, the patient's body would want to use water or additional water to properly dilute the urine. So therefore, patient who has type 2 diabetes or a diabetes issue tend to develop also polyuria and polydipsia. So polydipsia, polyuria, polyphagia should be the three polys that you need to remember. Okay, so polydipsia is abnormal thirst, so really, really thirsty. Polyuria is frequent urination, and polyphagia, which is increased food intake. So you might wonder why patients have polyphagia, even though they already have a lot of glucose in their body or in their bloodstream. How come they still eat a lot? Because even though you have a lot of glucose available in the bloodstream, their body tissue cannot use it without the help of insulin. Okay, so, or cannot use it a lot. So the cells are not nourished properly because the sugars are all just sitting in the bloodstream. So then it causes the cells to want to have more nutrients, which then increase the person's hunger. And if you increase hunger, then they want to eat more food, right? Funny thing is, despite this increase in their food intake, the body is still unable to metabolize the food, and the patient actually loses weight sometimes. Okay, so because the carbohydrate cannot be properly used, and if further protein and fats break down in this situation and ketone then forms again, then patient will develop also diabetic ketoacidosis. It is important to know that when patient is going into the ketoacidosis, there's a special type of breathing called Kusumo's respiration, which is fast and deep labor breathing. This is very common in ketoacidosis, so you should highlight that and make a note of the Kusumo's respiration. This is linked to ketoacidosis. Now let's look at the common signs and symptoms, and like I talked about the three polys, polydipsia, polyuria, and polyphagia. In addition to those three polys, patient may also experience weight loss, dehydration, blurred visions, thirst, infections such as skin, urinary tract, and vaginal infection. Why do they have increased risk for infections? Because there's excess amount of glucose in their blood, and who doesn't like glucose, right? So bacteria loves glucose as well. So with increased amount of blood glucose, it actually increases the risk of bacterial growth. Okay, so it actually bacteria feeds on the glucose, and that supports them to grow even more. Okay, and also the vision changes. We know that diabetic patient also has a complication called retinopathy. This is associated because of the hypertonicity of the body fluids affecting the cells in the lens and the retina. Okay, so that could cause some acuity changes in their eyes as well. And diagnostic findings, how do we diagnose someone with diabetes? We would take their urine tests to see if there's glucosuria in there, excess amount of glucose. We can also check their blood sugar level using a glucometer, which is much simpler and fast. However, there's limit on glucometers, so we must know what is the highest value that can be processed through the tiny glucometers. Most of the ones in the hospital can process up to about 600, and the lowest to somewhere around 40 or 30. So if your patient has excessive amount of blood sugar level, sometimes the glucometer cannot detect because it's way too high or way too low. In that case, then a blood test needs to be drawn. So patient will be asked to actually be drawn through their veins and get that blood level instead of the glucometers. Okay, so A1C test again is also important to see how well the patient is managing their diabetes, and those are the general tests that we use to diagnose someone with diabetes. So in terms of medical management for diabetes, regardless of the type of diabetes, we are, as nurses, we need to educate, monitor, help them with their meal planning, and promote exercises. Okay, so diet and weight loss is actually one of the major components here. The overall goal obviously is to assist the patient to make changes in their nutrition and exercise habits. That way they can improve their metabolic control and to maintain a healthy serum glucose level. Now, so we wanted to focus on what are some of the ways that we can help them with. In terms of diet, they need to be looking at what is allowed for their calories, carbohydrates, fats, and proteins. We want to educate them on different type of carbohydrate foods that can affect the blood glucose levels, especially looking at the term glycemic index. So the glycemic index can measure how fast a carbohydrate food is likely to raise the blood sugar. So for someone who has diabetes, they should be choosing food that are low in their glycemic index so that it doesn't change your blood glucose level too quickly. Foods that are high in their glycemic index, something that's greater than 70, such as waffles and donuts, that are most of them are our favorite type of food. it will raise the blood glucose level too quickly. Okay, so we wanted to pick something that is low in their glycemic index and educate patient on that as well. They should also be educated on reducing the use of simple carbohydrates, saturated fats, and alcohol. Okay, so it's very important that patient adhere to the ADA diet, and then we can talk about exercises. So patient with diabetes should exercise regularly, and of course, it will be under the direction of the primary care provider to determine which type of exercise is best for the patient. But we all know that exercises is beneficial, right? Because it not only help the body properly use up the glucose, but it also is important for our overall functioning of our cardiovascular system. And proper exercise can lead to weight loss, which is one of the focus for diabetic patient. We wanted to make sure that patient's overall well-being is good. Okay, so exercise can, because it's going to use up the glucose, so it can reduce insulin resistance and increase glucose uptake. Okay, so not only it can do that, what else can it do? It could reduce our blood pressure and our lipid levels, right? So that's how great exercise is. Now, knowing that it can drop the glucose level, there are some risks with hypoglycemia. So patient should have a complete physical before beginning any sort of rigorous exercises. Medication exercises should be adjusted to improve the blood glucose control. That means you do need to know if patient is going to go for an extraneous exercise, then their glucose level should be measured. Okay. Why is that? Because if the patient's current glucose level before exercise is already less than 100, and guess what? When they exercise, what happened is going to drop it further, right? So if the patient's glucose is less than 100 before exercise, they should intake some sort of carbohydrate snack before they begin to exercise. Now, if the patient glucose level is really high, like in the 250s, before they exercise, then patient may have too much ketones during exercise, so they should talk to their healthcare provider before they exercise. Okay, so the key is we want to educate the patient to maintain a consistent and also a moderate type of exercises to help the blood glucose control better. Now, thanks to our research advancements and medical advancements, now we have many types of insulin. We have insulin that are human form. We also have insulin that are made from beef and pork pancreas, but because we already have the human forms of insulin, very, very few people are using the beef and pork insulin made from the pancreas now. There's also alternative ways to injection, which is a transdermal insulin patch system that is currently being developed right now. So we can talk about that further in other discussions, but I do want to focus on the different type of insulins that we have currently. Right now, we have 4 different type of insulin, and they are 1, rapid acting, 2, short acting, 3, intermediate acting, and 4th is the long acting. So it is important for the students, you guys, to know what are the some of the medications that are categorized in the rapid acting, what are medication categorized in the short acting, what are some of the ones in intermediate acting and long acting. So the easiest one is to remember the long acting first, because there's only 2 medications out there that are long acting. Number 1 is Glargine, and the trade name is Lantus, and the second one is Detamir, and the trade name is Levemir. So Glargine is used once a day, generally at bedtime, and it works around the clock for 24 hours. So make sure you understand long-acting does not have a peak. Okay, so it doesn't have a peak time for long-acting. It just works throughout the day for 24 hours. Now, the next one to remember, I think it's easier, is the intermediate acting ones, which is our MPH insulin, which is the cloudy one. Sometimes it can be combined into 70-30, so like, or 50-50, so we have some portion of intermediate acting and some portion of short acting as well. Now, the rapid acting versus short acting, the short acting is what we call the regular insulin. So regular insulin is clear, and some of the names are Humulin R, Novolin R, right? You guys heard about these two. That's short acting. Then we have the rapid acting. There's three common ones that belong to rapid acting, and they are Lispro, Aspart, and Glulicin. So that Lispro's trade name is Humalog, Aspart's trade name is Novolog, and Glulicin's trade name is Apidra. So these are the common ones, although they're not the only ones. Okay, so make sure you know the difference between these four different type of insulins. Very important, super important. You need to know the onset for rapid acting, you need to know the peak and duration for all four categories, okay? Which is listed in table 51-3. Go through them, and they're also in your ATI pharmacology book. The most common way of injecting insulin is through subcutaneous, and some of you may already have experience injecting subcutaneous insulin. You have to pick the right needle as well, okay, so don't forget about that. Make sure if you have to mix insulin, so this is also part of administration of insulin, then you should remember something, maybe this will help you. I remember if I need to mix insulin, I go by N, R, R, N. So basically it means first you need to inject air into the MPH or the cloudy vial. Okay, then you inject air into the regular insulin. Now you flip it over, then you draw the medication from the regular insulin, and then you take the needle out and draw it from the MPH. So the way I remember is NRRN. Okay, the top two is where you inject air, depending on the dose. Sometimes the doctor may order, 10 units of MPH, and then let's say 5 units of regular. So you're gonna inject 10 units of air into MPH, take it out, and then inject 5 units of air into regular vial. Then you flip over the vial and draw 5 units of regular, and then lastly you're gonna draw 10 units of MPH, totaling 15 units. Okay, so that's preparation of mixing two different type of insulin. So make sure you know that. Now, when we're giving subcutaneous injections, you need to know where the site is. So generally, we have given it in the abdominal fatty tissues. Make sure you know that you need to leave space about 2 inches around the umbilicus. You are not going to inject insulin in that 2-inch circumference, 2-inch diameter. Okay, so you can inject on the side, or you can inject it in the back of your hand, back of the forearm here. So you also can do that, or on top of the thigh and the back, right above the buttock region. But the most common site is abdominal and back of the arm. Okay, so that's just general subcutaneous injections. For IV, IV, the only time we use IV route is when the patient really needs insulin fast. So let's say someone who's going into ketoacidosis and we need to give them IV insulin intravenously, and the only medication that can go into IV is regular insulin. Okay, so the short-acting regular insulin. Someone who requires IV route will need to be monitored very carefully. They will be checking their blood sugar level almost on an hourly basis. Okay, so that's IV. All right, we need to make sure we are changing our sites, rotating our subcutaneous sites to avoid lipoatrophy, right? We don't want the subcutaneous fat in that area to be getting these repeated injections. It may build up in the subcutaneous fat, okay? All right, now there's insulin pen as well. Insulin pen makes it a lot easier, and some of you can see the figure 51-7. You can there's a dial in the back of the pen. You can dial to the amount that is required to give to the patient, and the proper way of administering insulin pen, make sure you are administering at a 90-degree in the abdominal tissue. Okay, so you inject and then you press onto the dial. Make sure all the insulin has been administered before you release it and remove it from patient's skin. All right. We also have jet injector and insulin pump. Okay, so insulin pump provides what we call a continuous infusion, and generally it's used in a patient with type 1 diabetes that they need continuous insulin. So the pump itself has a reservoir for both the rapid acting or the short acting, and it's battery operated, so they need to be checking when to change the battery. They usually have it like a belt to go over the patient, but that's all I wanted to talk about the insulin pump. Okay, and let's go to the next slide. This slide talks about the oral antibiotic agents for type 2 diabetes. I'm not going to go through most of the oral drugs here in this lecture. I will go through it in another lecture. I will be using the ATI Farm book to help you guys with the lecture on oral medications. So we'll go through that later. Now, looking at the nursing management, there are quite a few things that the nurse has to monitor. So we would do a lot of education with our diabetic patient, and first is to teach them how to properly and accurately monitor their blood glucose levels. So educating them on how to use the glucometer is one of the main things we have to teach them, and when to be checking. We do want to educate the patient on things like physiologic or psychologic stress. If they're experiencing any stress, that could raise their blood glucose level. So especially with type 1 diabetes patient, they should not be withholding their insulin at all without consulting with the healthcare provider, right? Because we know that if they withhold their insulin, what happened is without the insulin, the body does not promote glucose to enter the cell. Then the cell will seek an alternative source of energy, which is going to be the fats and proteins. And then when these are broken down, then ketones are formed, right? And for type 1 diabetes, when ketones are formed, it will result in ketosis and acidosis very quickly and will put them in a bad situation, what we call the diabetic ketoacidosis. So make sure we know that, especially type 1 diabetes patient. Also, we wanted to make sure we educate them on how to properly administer the insulin injection sites and the areas of the skin that is appropriate to be giving the medication. We also want the patient to be assessing their skin, because of the poor circulation can lead to a lot of skin problems in diabetic patient and would put them at risk for infections. we know that there's quite a bit of vascular changes with the decreased oxygen and increased blood glucose level. It will cut down the nutrition supply to the tissues and also will cut down the white blood cell being available to the area of the tissue. So if there's any abnormal cuts, scratches, or lesions found in the body, we want the patient to notify the physician right away. Now, for diabetic patient, you need to be thinking about foot care, right? Proper foot care or special foot care. Because of why? Why should they be looking at their foot care? Because they have poor circulation and decreased nerve sensation of what we call neuropathy. Okay, so with neuropathy, there's a lot more inflammation and degeneration of the peripheral nerves, which can increase the danger of ulcer formation or any other abnormal blood flow that can cause gangrene. So patients should be seeking services from podiatrists about their foot care if they don't know how to properly care for their foot. Now, very easy, we need to know, and you should know this, patient can wash their feet thoroughly with mild soap and warm water every day. They can, check the temperature first with their hands before they put their foot into it. They should also be patting their feet dry gently, especially between the toes, right? Because moisture do accumulate between the toes, and that could cause more mold or other fungal infection. They should be examining their feet daily for any cuts, blisters, redness, or any tender areas. Other than that, can they be using lotions on their feet or between their toes? No. Okay, they shouldn't be doing that. But if they do see a lot of dryness and crackling, they can use lanolin. That's okay, but still not between the toes. Only on the dry portion of their feet, if there's any crackling going on. Also, they should cut their toenails even with the rounded contour of their toes, which is okay, but they shouldn't be cutting down those corners. Okay. Also, when is the best time to trim nails? After shower or after bath, right? Because at that time the nails are more softened. Okay. They should always be very careful with putting on heating pads on their feet or one of those warmer pads because burns may happen, and due to the fact that they had neuropathy, they will not be able to feel it. Patient also should be wearing sturdy and proper fitting shoes, so they need to avoid open toe shoes, open heel shoes, even high heel shoes. Those are not acceptable for them because it's going to put them at risk for foot problems. As far as socks goes, they should be wearing clean, absorbent cotton socks. Okay, cotton socks, not other type of fabric. Also, to be careful with their clothing. The clothing should not be too tight because if it's too tight, it will constrict circulation and will cause more problem with nerve sensation and circulation. If they live in a very cold area, they should have proper guard against frostbite. And another way to increase circulation is to exercise their feet daily, either be walking or flexing or just like extending the feet will all help with the circulation. Another thing that prevents circulation is prolonged standing, prolonged sitting, or they cross their legs. Okay, crossing the legs will decrease circulation. So these are all proper foot care for a diabetic patient. Besides foot care, we also wanted to think about eye exams. They should be getting eye exams every 6 to 12 months to diagnose any diabetes-related vision issues like retinopathy that I mentioned earlier. And the next thing is to educate patient on signs and symptoms of hyper and hypoglycemia. So patient should be aware that during hypoglycemic state, they may feel dizzy, shakiness, irritability, headache, okay, cold during hypoglycemic symptoms. And then if they are experiencing hyperglycemia symptoms, they should have also becoming the polys, right? The three polys: polydipsia, polyphagia, polyuria, right? And they should be feeling really hot, okay? So hyper is hot, hypo is cold. All right, so signs and symptoms of hyper and hypoglycemia, also very important to educate the patient on. I already talked about diet and exercise earlier, so that is also should be included into the nursing management and